Good morning. My name is Denise Ballard, and I'm the Program Director of Community Outreach and Engagement at Winship Cancer Institute of Emory University. And it's my pleasure to present our first speaker today, Dr. Kevin Ward. Dr. Ward is the Director of the Georgia Center for Cancer Statistics and Assistant Professor in the Department of Epidemiology at Rollins School of Public Health of Emory University. Dr. Ward has extensive experience with cancer surveillance and control activities, population science, population-based registry data, registry operations, and the use of the registry for research purposes, among several other responsibilities. Dr. Ward's presentation today is entitled Population Data on Cancer Outcome Disparities in Georgia. Dr. Ward.
Good morning. Thank you very much. Are you able to see my slides?
Yes, we are.
Okay, wonderful. Thank you. So I'd like to thank the organizers of this symposium for the opportunity to share some of our Georgia Cancer Registry data on cancer outcome disparities in our state. This is a fairly large slide deck, as there is a lot to cover, but we'll move fairly quickly and I'll hit the highlights for you. So I'd like to start with a short story of something that happened personally back in November of 2010, so about a year ago from now. A 67-year-old female in November of 2010 was experiencing dysphagia, had an EGD with a biopsy, and was diagnosed with a distal esophageal adenocarcinoma that was grade 2 extending into the cardia. It was around 6 centimeters in size. The individual had a PET scan and a CT, and it was identified that the tumor invaded the muscularis propria. 4 paraesophageal lymph nodes were involved, and the case was staged, a T3 clinically, a T3 into M0. About 2 weeks later, the individual started neoadjuvant multi-agent chemo with the 3 agents you see there, and had 3 cycles. Several months later, in March of 2015, the individual had an esophagogastrectomy. At that point in time, there were 0 of 27 lymph nodes that were identified as pathologically positive. And in fact, there was no residual disease. And this individual was my father. And we know that survival is quite poor for patients with esophageal cancer, and especially with these disease characteristics. So I've often wondered why this outcome for him. I feel confident my father had favorable molecular characteristics in terms of his responsiveness to chemo and the fact that he was pathologically negative following his treatment. But for that to be a benefit, he actually had to receive and complete his neoadjuvant therapy. And so my father had a number of things that were in his favor in that regard. He was financially well off. He had good insurance. He did have comorbidities, but he had managed them well and was in regular contact with his primary care physician. He had access to exceptional care and in fact received care at our own Winship Cancer Institute by 2 exceptional surgeons and a wonderful medical oncologist. He had a good social support system and an advocate who could help ensure that he continued through all of his care, received all of his treatments, and then did all of his follow-up care. And of course, he had a strong faith as well. When I look in the registry, the Georgia Cancer Registry from 2007 to 2013, around the time period of my father's diagnosis, there's around 189 cases of individuals with esophageal cancer of the lower third of the esophagus. And down at the bottom of the screen, we see the characteristics of those who are still alive. It's around 13–14% overall. And when we look at the bottom of this, this figure, I think it's a striking characteristic of the disparities that do exist. And they exist largely around things like poverty, where we see that among individuals who were diagnosed while residing in areas of high poverty, those with greater than 20% of the population living below the federal poverty level, only 5% of those individuals diagnosed during this time period with these characteristics are still alive, relative to 15% of those who are in lower poverty areas. And so the National Cancer Institute defines disparities as the disproportionate burden of cancer borne by certain population subgroups. And we know that disparities predominantly arise from inequities that exist in things like wealth and education and the environments in which we live and our standard of living, as well as barriers to high quality cancer prevention, early detection, treatment services. And I think we've seen across all diseases within our state, not just cancer, that the poor and the medically underserved are disadvantaged. When we talk about outcomes from population-based registries, we can look at things like incidence and mortality and survival, stage at diagnosis, the treatments patient received, quality of life, or even downstream recurrence. We know there's a host of contributing factors that play into disparities that are observed in cancer. But specific to our registry, we're able to look at largely area-based measures of socioeconomic status and as it relates to being able to calculate rates. But area-based measures of SES, we can look at differences by geographic location. And then of course, we can look at differences by race. So the goal of this talk really is to share some of what we know in Georgia about cancer disparities and hopefully to empower some of you to address these disparities in your own work through registry-based research. So some of the speakers that will follow in today's symposium will describe their own research that is utilizing the Georgia Cancer Registry to help address some of the disparities that are known within our state. A little background on the Georgia Cancer Registry and some of the keys to utilizing a registry for research. I think first and foremost, we're population-based. And so we do try to capture every case of cancer that occurs within our catchment area. And by doing so, we can look at non-response bias. So we're able to adjust some of our analytic results for individuals who do not respond because we have many of their socio-demographic and clinical characteristics. It's also important to note that we do have legal access to PHI in the state of Georgia through the registry. So cancer is a reportable disease, and we have the legal authority to have access to that PHI, and reporting is HIPAA exempt. And so physicians all across the state of Georgia provide data on cancer patients to our registry where they're aggregated and utilized for a variety of different activities. The Georgia Cancer Registry and all population-based registries were founded on hospital-based systems. And so we largely collect data that comes in from our hospital systems across the state. But we also follow patients. We follow them longitudinally for outcome and the predominant outcome of mortality. We capture the residential address of every patient at the time of diagnosis, and we link those to census data to get area-based measures of socioeconomic status. We link our data both with our state vital records on a routine basis and with the National Death Index on an annual basis. Because we know today that more and more cancer patients are receiving care outside of our hospital systems, we receive reports that come in through meaningful use from private physicians across the state, as well as from freestanding oncology providers for medical oncology and radiation oncology. In the state of Georgia, we have real-time pathology reporting. So path reports are coming to us from labs all across the state and from most of our large cancer centers and hospitals in the state of Georgia. So we have real-time access to pathology data within our state. We have an interstate data exchange agreement with every other state in the US. So we share data on patients who go elsewhere for treatment along with those who come to Georgia for treatment who were diagnosed in other states. We've begun to link our data in the registry with administrative claims data. We receive real-time pharmacy transactions on oral oncologics from CVS and Walgreens. We've done some linkages with the registry. We've linked all of our breast and ovarian cancer cases with 4 of the largest genetic testing companies in the United States. And we're initiating a series of linkages with genomics labs as well. And finally, Dr. Lash and I in the Department of Epidemiology have a current R01 that's focused on adding recurrence data into the Georgia Cancer Registry. So when we look at our population, Georgia's population in 2018 was around 10.5 million individuals. You can see we're the 4th largest African-American population in the United States, with around 32% of our population being African-American, and that comprises about 3.4 million individuals. We have a growing Hispanic population. Around 10% of Georgia's population is Hispanic today. When we look at county-based measures of socioeconomic status, on the left-hand side, This is an area-based measure of SES based off of county level poverty. And we can see that 25.8% of our population live in areas with greater than 20% of that population living below the federal poverty level, which in 2018 was around $25,000 for a family of 4. On the right-hand side, we can see we have about 17% overall of our population that lives in non-metropolitan areas. And so these maps are of our Georgia population, all of the counties within our state, and they're just designed to help you get a sense of the population by county. So we have a lot of really small counties in terms of population size within the state of Georgia. Most of those in white and purple are populations below 50,000 individuals. All of the populations in the counties that you see in brown and yellow and blue, those are the larger populations within our state, and they largely form the metropolitan statistical areas that you see over on the right-hand side of the screen. Georgia's population has a lot of counties that are below the federal poverty level or have a sizable proportion of the population living below the federal poverty level. And that's these counties that are listed in blue, mostly in the southern portion of the state and then along the eastern edge of our state as well. In this presentation, I'm going to focus predominantly on the outcomes of incidence, mortality, survival, stage at diagnosis, and then touch briefly on treatment. And in terms of cancers, I'll discuss cancer statewide. We'll talk about some of the leading cancer sites. And then I'm going to highlight the cancers that will be discussed in this symposium. And some of the characteristics of those cancers, so breast, ovary, lung, colorectal, myeloma, and prostate. In terms of the registry factors, again, we'll look across measures of poverty for SES, location, metropolitan versus non-metropolitan, and then race as well. So as it relates to incidence, this chart shows for our most recent diagnosis year. So registries, we are behind in our data capture, but this is for diagnosis year 2018. You can see the top 10 cancer sites by gender. Males have higher incidence overall than females, with about 27,500 cases overall compared to 26,000 for females. We do have around 54,000 invasive, so these are invasive cancers per year in Georgia. About 2,200, in addition to these, we have about 2,200 benign and borderline brain and CNS tumors that we started collecting our registries in 2004. And about 5,000 in situ cancers, mostly split between melanoma and breast. Overall, the age-adjusted incidence rate for Georgia is 466 per 100,000. And on this map to the left, you can see counties that have a higher incidence rate than the state as a whole, and those are the ones in orange. And the states are the counties that have lower incidence rates than the state as a whole, and those are the ones in blue. So we have an area up to the northern corner of the state around Dalton. And then we have this southern belt kind of through the middle of Georgia, where we have a series of blue counties that form a line going across the state with significantly lower rates than our state as a whole. But we have quite a wide variation in rates if you look at the chart to the right by county. So our rates range anywhere from 588 per 100,000 overall, to a low of 314 per 100,000 in Telfair County. So quite a bit of disparity across our state by geography in our counties. All of our data in the Georgia Cancer Registry is about to be published in our most recent report that's listed here at the bottom. It's in press now and awaiting approval, and I'll make sure that you're all aware of it as soon as it's published. It does provide data at the county level. It gets difficult to look at some of our cancer sites, individual sites, by other characteristics because of small populations, but we do provide overall incidence by county as well. When we talk about statewide incidence over the last 5 years, you can see here that males have higher rates than female, with the exception of the Asian Pacific Islander population. Males have higher rates with increasing poverty, whereas females have lower rates with increasing poverty. And we know that's largely driven by cancers like breast, where there are certain risk factors in women with higher socioeconomic status. There are similar incidence rates overall between metropolitan and non-metropolitan areas. We do have as it relates to race, you'll see the lowest incidence rates statewide, both for males and females, are among the Asian and Pacific Islander population, followed by the Hispanic population within our state. Black males have the highest incidence rate for men, and white females have the highest incidence rates among the females. This is a table that we'll look at several times for different races and genders, but or measures and genders, but it's looking at the relative ratio of incidence rates comparing high to low poverty areas. And so what it highlights, a relative ratio, if you look at the far right-hand side, a relative ratio greater than 1 would mean that the high poverty area has a greater incidence rate than the low poverty area. And so these are ranked. So if one were to focus on reducing relative rate disparities, you could look at the cancers at the top and the bottom of this specific list. And so those at the top of the list, such as vagina and esophagus and cervix, are where the individuals who reside in the high poverty areas have considerably higher relative ratio of rates compared to those in the low poverty area. And the reverse is true at the bottom of the chart. So down at the bottom, we see for melanoma of the skin and thyroid and the ureter, the rates are considerably higher in the low poverty areas relative to the high poverty areas. So I'm going to look at the cancers that are, and I'll present a series of slides like this where we focus on the cancers that are a part of this symposium. But when we look at female breast cancer or female cancer incidence, this is among females. These are age-adjusted rates 2014 to 2018, and this is by poverty. We can see that colorectal cancer, lung, and melanoma have increasing incidence with increasing poverty, whereas breast and ovarian cancer have a reverse pattern with higher incidence in the lower poverty areas. And we know this to be true for breast and ovary based off of certain risk factors, as I've mentioned earlier, for these specific diseases. As it relates to metropolitan versus non-metropolitan rates of these cancers, we see similar patterns to poverty, with colorectal and lung having higher incidence in non-metro areas, and breast and ovary having higher incidence in metropolitan areas. With the exception of ovarian cancer, our lowest incidence rates among females are among those of Asian and Pacific Islander populations. There are slightly higher rates in Georgia, as there have been for quite some time, in breast cancer for African American, and there are also higher rates in African Americans for both colorectal cancer and for multiple myeloma. Switching over to males, this shows the relative ratio again of the incidence rates for men. And so at the top of the chart, those where the rates are considerably higher, set around 70% higher in the high poverty, or individuals residing in the areas with high poverty relative to low, or the cancers of the larynx, the nose and nasal cavity, other leukemia, and stomach. And then again, down at the bottom, we see the similar cancers for men as we do for women, where those residing in the lower poverty areas have higher incidence rates relative to those in the high poverty for melanoma, eye and orbit, thyroid, and testes. As it relates to the incidence rates by poverty among men, we see a higher incidence with the exception, with increasing poverty with the exception of prostate cancer. So that's true for colorectal cancer, where we see a very clear pattern as well with lung cancer and multiple myeloma. We see in relation to the metropolitan versus the non-metropolitan areas, again, individuals very similar to females living with or diagnosed with colorectal and lung cancer have higher incidence. In the non-metropolitan areas, individuals diagnosed with prostate and multiple myeloma have higher incidences in the metropolitan areas of our state. As with females, across all cancer types, we see the lowest rates of cancer among males who are of Asian and Pacific Islander race. There's a striking difference, as we all know, in the high incidence rate of prostate cancer for African American males. And we also observe a higher incidence in African American males for colorectal cancer and multiple myeloma, as we know. Switching to mortality, So these are the top cancer sites of mortality within the state of Georgia for diagnosis year 2018. We have around slightly over 17,000 deaths from cancer annually within our state. Lung and bronchus is the leading cause of death for both men and women, followed by breast and colorectal in females and prostate and colorectal in males. When we look at the state as a whole, the mortality rate for our state overall is 161.5 per 100,000. And again, you'll notice we have a significant difference in mortality by county, with rates in the highest county of Glasscock of 244 per 100,000 relative to the lowest mortality rates within our state in Webster County of 103.9 per 100,000. There are some fairly wide confidence intervals with these, as the numbers do get small within some of our counties. Again, higher rates of mortality are scattered in a variety of counties across our state. We see lower rates than the state as a whole in terms of mortality in the metropolitan area. So our metropolitan statistical Atlanta area has lower rates. And again, we see some sort of pattern along that belt ranging from Brunswick down there in the south, where we see those two counties down below Savannah that are in blue with lower rates in the state, running over, to the left portion of the state. We see two more counties. So we have that similar belt that has some lower mortality rates within our state. When we look at the characteristics by statewide mortality, males have higher mortality rates than female. We see a consistent trend with increasing mortality in our state for both males and females with increasing poverty. We see a consistent trend of higher mortality rates in non-metropolitan areas and non-metropolitan counties within our state. Hispanics actually have the lowest mortality rates, both for males and females statewide in Georgia, followed by the non-Hispanic, the non-Hispanic Asian and Pacific Islander population. And African-American have the highest mortality rates, both for males and females. When we look at the relative ratio of the mortality rates, and this is for females, we can see that the largest differences are between, in terms of the higher poverty areas having higher rates, or with cervix, other leukemias, and cancers of the esophagus. At the other end of the extreme, down at the bottom end, there's only 5 sites that have higher mortality in the lower poverty areas, and those are brain and central nervous system, ovary, intrahepatic bile duct, other biliary, and melanoma of the skin. When we look at mortality rates during this same time period, 2014 to 18, with the exception of ovary, we see a consistent trend of increasing mortality with increasing poverty. Similar patterns are seen when we look at the characteristics of metropolitan versus non-metropolitan, with higher rates, generally speaking, in our non-metropolitan areas for cancer mortality, with the exception of breast and multiple myeloma, where the mortality rates are roughly equivalent. We have consistently lower mortality rates, as we did with incidence, and of course, incidence and mortality are correlated. In the absence of survival differences, we would expect our mortality patterns to mirror our incidence patterns, but we see consistently lower mortality patterns in Asian Pacific Islanders and in the Hispanic populations. And we see higher mortality in breast and colorectal cancer and myeloma for African Americans, and higher mortality among whites, and strikingly so for lung cancer. These are the relative rate ratios of mortality rates. Again, comparing the high to low poverty areas by site for males. We see the largest relative difference is seen for larynx, stomach, and lung, comparing the high to the low poverty areas. And again, down at the bottom, there are only 3 sites that have higher mortality in low poverty areas, and those are urinary bladder among men, melanoma, and brain and other central nervous system tumors. So among our male cancers, we have a very consistent pattern when we look at it by poverty of consistently higher mortality with increasing poverty area-based poverty within our state. And we see, again, very similar patterns when we look at our metropolitan versus non-metropolitan areas, with especially for lung and colorectal cancer, and especially with lung cancer, with striking differences in lung cancer mortality rates in our non-metropolitan areas. By race, we have consistent lower mortality rates, again, as we did with females, with the Asian Pacific Islander population and our Hispanic population. And of course, one of the most striking mortality differences that we see is the considerably higher mortality in African-American men with prostate cancer. And they also have higher mortality, African-American men with colorectal cancer and myeloma as well. So transitioning to survival. So this table shows the 5-year relative survival rates from 2013 through 2018. On the left-hand side, we have males, and on the right-hand side, we have females. At the top of the chart are the top 10 cancers in terms of relative survival, and in the bottom are the bottom 10 in terms of relative survival. In our population-based registries, we do traditionally utilize relative survival, and it's a net measure of survival where we take the observed survival in our cancer cohort divided by the expected survival from a general population cohort matched on characteristics of risk like ACE range and time period. We have historically done that because of some misclassification that we expect and have seen to exist in cause of death data, although that has dramatically increased with some of the sophistication and automated coding of death certificates today. So we can produce survival statistics as well using cause-specific survival, because we do capture cause of death on all of our cancer cases. But you can see the top cancers in terms of survival rates or survival proportions among men are prostate, thyroid, melanoma, and testes. And those at the bottom are lung and bronchus, mesothelioma, pancreas, and intrahepatic bile duct. For women, the leading cancers in terms of survival are thyroid, melanoma, breast, and Hodgkin's lymphoma. And the same crew falls at the bottom as mesothelioma, intrahepatic bile duct, and pancreas. For most of our cancers, and it's clear here with the female cancers, when we look at survival by poverty, we see a very consistent trend of decreasing survival with increasing poverty. And again, a very similar pattern as well when we look and compare the survival differences in our metropolitan areas versus our non-metropolitan areas, with a consistently lower survival in our non-metropolitan areas. Looking by race, in 5-year relative survival, we see that the black-white survival is comparable for colorectal and lung, but African Americans have lower survival for breast and for ovary, and higher survival for myeloma. Because survival data, unlike mortality data, are based off of an incident cohort, we're able to look at survival by other characteristics, clinical characteristics associated with the individual's diagnosis. And so this is looking at survival by stage. And so we can see that we do see larger differences in black-white survival with increasing stage. So the differences between the groups becomes larger in terms of decreased survival for African Americans. Interestingly, and something worth looking into, the higher survival in distant stage that's observed for the Asian and Pacific Islander population here in Georgia. We of course, these are just point estimates. We don't have confidence intervals presented here, but it's something worth looking into a little bit further. We do capture the stage distribution, and so we can see that a larger proportion of non-white individuals with breast cancer are diagnosed at later stages. 65% of non-Hispanic whites are diagnosed with localized disease, meaning confined to the organ of origin, relative to 55% for non-Hispanic blacks, 58% for the Asian and Pacific Islander, and 53% for the Hispanic population. Looking at female ovarian cancer, we do see lower survival with localized disease for the Asian Pacific Islander and Hispanics. So this is one of the cancers where we do see lower survival in that group. Higher survival with distant diseases, interestingly, again, for the Asian Pacific Islander population as well. And again, we can present these same characteristics by stage, and see we actually have fairly similar, with the exception of the Hispanics. Most of the racial ethnic groups tend to be diagnosed at later stage with this disease, but non-Hispanic whites and non-Hispanic blacks at a larger proportion than our Asian Pacific Islander population and Hispanic population. So this is now switching to survival among males. And again, just as we saw with females, we see very consistent trends in decreasing survival with increasing poverty, with the exception of multiple myeloma. We again also see a very similar pattern as what we saw in women when we look at metropolitan survival among individuals residing in metropolitan versus non-metropolitan areas, with lower survival among those residing at the time of diagnosis in the non-metropolitan areas. And finally, when we look at survival by race, we have comparable survival in prostate and lung cancer across the races, with the exception of Hispanics who tend to have a little bit lower survival for prostate cancer and a little bit higher survival for lung cancer. Higher survival for whites for colorectal cancer, and higher survival for Asian Pacific Islanders and African Americans for myeloma. So in our registry, we do collect data on first course therapy, and we're looking to expand that data collection to other courses of therapy as well. So we are able to begin looking at disparities that exist in receipt of treatment for different patients of different characteristics. We define first course therapy as any therapy that's documented in a defined plan, or in the absence of a plan, therapies up to 1 year in the absence of disease progression. And so we collect very detailed surgery data. We have data on radiation therapy that's fairly comprehensive as well. Chemotherapy our data is somewhat limited. It's basically single agent versus multiple agents. Same with immunotherapy. As I mentioned earlier, we are now linking our data with a variety of claims data sets. And so we do have some longitudinal claims-based treatment data that exists within the registry. And then since 2013 forward, we have all of the pharmacy transactions from CVS and Walgreens on patients who were Georgia residents and received oral oncologics from those pharmacy chains. So just as an example of what can be done with registry data and looking at stage 3 colon cancer patients, we know that they are indicated under guidelines to receive chemotherapy. This is just a cohort of 2017-18 diagnosis year stage 3 colon cancer patients who are between the ages of 20 and 79, and there was around 1,300 of these individuals. And we can see from registry documentation of chemo that there's fairly comprehensive capture within our registry with and it's fairly similar, at least between non-Hispanic blacks and whites, with around 80% receiving documented chemotherapy for stage 3 colorectal cancer. It's higher among Asian and Pacific Islander population, with 88% receiving documented chemotherapy, and lower at 75% among the Hispanic population. So we did make an attempt to validate some of the ascertainment. The chemotherapy ascertainment registries have been criticized over the years for incomplete ascertainment of adjuvant therapies, and it's because many patients are receiving these therapies outside of the hospital systems that are the foundation, as I mentioned, of our cancer surveillance systems. But we had a 2011 to 14 cohort of stage 3 colon cancer patients who we had surveyed. There were 1,300 of them. It was our registry in Georgia and the other Syr registry at the time in Detroit. We had a 68% response rate from that survey. And one of the things that we asked the patients was, did they receive, and these were all stage 3 patients, did they receive chemotherapy? 85% of the individuals did document self-reported chemotherapy. And when we compared that against what we had in the registry, we had about a 6.8% under ascertainment by chemotherapy in the Georgia Cancer Registry. But fortunately, it was not differential, across any patient attribute. So the under ascertainment didn't vary by patient characteristics. So I'd like to end by just taking a few moments to talk about how you can use the GCR as a resource to support research to address cancer disparities within our state. So we, of course, have descriptive data like what's been presented today. Our data is publicly accessible, and we're happy to provide any descriptive data that any individual would like. If you'd like to dive into the data at any point in time, feel free to reach out and we'll be happy to help facilitate that for you. Our registry data is well positioned for survival studies as we do follow all of our patients following diagnosis until death, and we have very complete ascertainment of follow-up in the registry. Because we have the legal authority to have PII on all cancer patients within our state, we can support linkage studies. So if you'd like to link the Georgia Cancer Registry data set to a data set you have at Winship, or and include additional information out of the registry that you may not have in your data set, or link any registry data set to another cohort, we can facilitate those kinds of linkage studies. Most of you know that registry data is linked with Medicare, and so we do have a Medicare data set that's available and is utilized by a lot of researchers across our state. And then we also, and this is what I'd like to just end on, talk about how we use the registry. And I think this is one of its most important features as a sampling frame for recruitment studies and for trials. And we do that through two different ways. We can use the registry itself, or through our electronic pathology data, we can do what's called rapid case ascertainment. And so I wanted to just give you two examples of these types of studies. And so the first is the RESPOND study. So this is a comprehensive and integrated approach to trying to look at these known disparities that exist in African Americans with prostate cancer. So this is a multi-site study. It was funded out of the National Cancer Institute. The award went to the University of Southern California. This is moonshot funding. And there's 8 different states that are participating in this specific project. There are 3 separate projects. The first is looking at examining associations between multi-level social stressors like those you see down at the bottom for African American men across their life course and the risk of aggressive prostate cancer. And how the registry facilitates this work is by sampling individuals, and we can sample individuals by risk category. So we can oversample individuals with more aggressive disease based off of the risk classifications that exist. And then because we have the PII, we're able to invite men to participate and complete a survey. We, of course, geocode our registry data, as I mentioned, and then we can provide area-based measures of SES, along with a clinical registry data set of the clinical characteristics of the cancer patients within our state. Project 2 within this was looking at the role that inherited variation plays in developing a greater risk of aggressive prostate cancer. And it's being done through genotyping as well as exome sequencing. And so the registry's role in that is for the men who complete a survey, we then reach back out to them and ask if we could obtain a saliva sample. We receive those samples and then ship them to the processing center. And finally, project 3 is looking at to try to delineate the genomic events and molecular signatures that might signify or signal aggressive prostate cancer phenotype in African American men. And so again, the registry, after men have completed a survey, those who complete the survey, we then request access to stored tissue, either from the biopsy or the prostatectomy. And we retrieve those from the labs and then ship those to the processing center. So our progress to date in this study, we have and again, this is an African-American male cohort. We have around a 39% response rate overall. But when you look at it among individuals we've been able to follow completely through the registry, it's pushing a 50% response rate, which we think is exceptional in this cohort. We have around 1,100 surveys that have been received to date. And among the men who have completed the survey, we get a 50% response rate to providing a saliva sample and to providing access to tissue, which again, we think is exceptional. One final example in disparities research utilizing registries is this Project Center grant that we had with the University of Michigan. It was looking at the challenge of individualizing treatment for patients with breast cancer. And in this study, because they wanted to ascertain patients shortly after diagnosis to be able to look at information in terms of the treatment experiences and decision-making, we use rapid case ascertainment. So we were able to review path reports as they came in real time to identify women who were diagnosed with breast cancer pathologically, and we did it following their surgery. And then we were able to reach out to those individuals to participate in a survey. 70% response rate in the state of Georgia in this breast cancer study. And we linked our data with both genomic and genetic results from industry. We also surveyed clinicians and had a 75% response rate from surgeons and a 60% response rate from medical oncologists. So I'm going to go ahead and end the presentation here in the interest of time. These slides will be made available. Part of what this study was focused on, or one of its major focuses, was on understanding more about genomics. And specifically, could we integrate genomics into our cancer registry data set? And so why? Well, we were interested in what can we learn about mutation prevalence in our cancer patients, and what proportion of cancers are associated with germline mutations, for example. And we were interested in things like, do disparities exist in cancer treatment utilization and outcomes? So do these mutations affect treatment choices? Is survival difference associated with particular mutations? And finally, can we target high-risk groups for prevention? And so across these 4 different questions here, we've initiated a paper that looked at the first in terms of the proportion of pathogenic variants in both breast and ovarian cancer patients by linking our data with 4 genetic testing companies, Ambry, Myriad, Invitae, and GeneDx. And I think from a disparities perspective, what we saw on the right-hand side, and this is, I'll end here, with ovarian cancer, we know that patients are supposed to receive genetic testing, and it's because, in more recent years, PARP inhibitors have been approved by the FDA, and they're specific for targeting women with BRCA mutations. And so we need to have our patients tested within the state. And this shows that in Georgia, and this is a 2013 to 14 cohort, these numbers do increase. We've done this linkage through 2019, 17 now. But in this cohort, only 30% of Georgia's ovarian cancer patients were receiving testing. And as you can see, there were disparities across all of the racial ethnic groups, by poverty, as well as by insurance, in terms of who is getting this genetic testing being done. So I'll end there, and I just want to thank you for the opportunity. I encourage you to please reach out if you'd like to discuss utilizing the registry to support your research, or if you'd like to take a more detailed dive at any of the data that we have for your cancers of interest. Thank you very much.